BPH or BPO. So the first speaker is Dr. Mark Wellmann, who's our General Registrar at Histology at the University of Cape Town. And the second speaker will be Dr. Amit Kaupi, who will be chatting to us about HOLEP. We'll just introduce him again when he's about to speak. If you're ready, Mark, you can start. Thank you.
All right. Thank you for the kind introduction, Sam. Good morning, everyone. I hope you can all see my slides. So today we're going to be talking about BPE and quickly touch on the pathophysiology and medical management as well. So the synopsis of today's talk, we're going to talk about the terminology, epidemiology, risk factors, pathophysiology.
Mark,
yes.
Mark, sorry, just when you're still starting, I don't want to disturb you. If you can just go to slideshow so you can have a bigger view of your slides.
Okay, is it not?
No, not yet. Your mouse is right on it. Your mouse is actually on it. You can just click so we can have a bigger screen. Perfect. Thanks a lot. You can go back to the first slide, please.
Okay, so we talking about BPE today, pathophysiology and medical management. So the overview of the lecture, we're going to discuss the terminology, epidemiology, risk factors, pathophysiology, touch on histology, clinical manifestations, briefly go through the evaluation, diagnosis, and then the treatment options. So BPE or BPH is often confused with benign prostatic hypertrophy, which is an archaic term for BPH, describing an increase in cell size rather than the cell number. And BPH is a term used and should be reserved for the typical histological pattern which defines a disease. BPH results in benign prostatic enlargement in some but not all men, and this enlargement can in turn lead to benign prostatic obstruction or BPO and bladder outlet obstruction. While BPH alone does not always require treatment, BPE and BPO are often associated with lower urinary tract symptoms, which may require treatment. The prevalence of the disease increases with age, and based on medical records, it's been estimated that nearly 70% of men in the US between the ages of 60 and 69, and nearly 80% of men above the age of 70 years have some degree of BPH. And the prevalence of histology diagnosed BPH also increases, much like the symptomatic. And mirroring the changes in BPH, the severity and prevalence of lower urinary tract symptoms also appears to be age-related. The risk factors, we have unmodifiable and modifiable risk factors. Race seems to be a risk factor in black and white men, with younger men being having a greater risk than white men. But the age-related relative risk is the same. And then in terms of genetic susceptibility, a number of surveys have been done in the US, which showed that between 40 and 70%, 70-year-old men, 21% of them had a family history of an enlarged prostate. Moving on to modifiable risk factors, we've got obesity and metabolic syndrome, and it seems to be related in part, at least, to an increased autonomic tone. And from the metabolic syndrome, from the obesity, glucose intolerance, dyslipidemia, and hypertension, this is exacerbated. The increased atomization of circulating testosterone in adipose tissue, which alters testosterone to estrogen ratio or hyperinsulinemia. And two meta-analyses found that men with metabolic syndrome had higher prostate growth rates and larger prostate volumes than those without. Beverage consumption, greater total or greater coffee intake increases the odds of Lats and Bph progression, while citrus juice has been associated with 50% lower odds of BPH and Lats. Physical activity, low levels of physical activity are associated with greater Lats development, and then moderate alcohol consumption is not associated with Lats, but excessive consumption, which is 3 or more drinks per day, may lower the risk of BPH due to the depression of androgen levels. Micronutrients have also been involved as they are prevalent or needed for the prevention of oxidative damage and cell growth and differentiation. So that your dietary lycopenes, beta-carotene, total carotenoids, and vitamin A are inversely associated with Lats, or the high-dose supplemental and total vitamin C are positively associated with Lats. Then just briefly touching on the cardiovascular risk factors, it's again, autonomic hyperactivity is believed to be involved in the development. Heart disease and hypertension are associated with greater severity of Lats. Heart failure, changes in cardiac ventricular pressure, release of BNP, and this can increase urine production, resulting in worsening of symptoms, especially nighttime symptoms. Some neurological conditions can influence the juicer function and stability and are important in BPE and Lats. And diabetes mellitus can also worsen Lats due to decreased bladder sensation, the juicer contractility, incomplete bladder emptying. And additionally, the polyuria from the osmotic diuresis can potentially worsen Lats as well. Moving on to the pathophysiology, it seems to be a multifactorial pathophysiology, the prostate playing a significant but somewhat overemphasized role in the etiology. If we look at the pathophysiology of Lats, we can think of it of having a static component, referring to enlargement of the prostate gland leading to BPO, and a dynamic component consisting of increased smooth muscle tone and resistance. BPE with BPO can have secondary effects on the juice activity, leading to the juice instability or overactive bladder. So this effect, in combination with age-related changes to the juicer contraction and compliance, compound BPE-associated Lats. In terms of the pathophysiology, there's several processes that are likely involved, including increased production of new epithelial cells, re-establishment of prostatic cells inductive potential, cell immortalization due to loss of programmed cell death, and prostatic inflammation. A number of newer studies have shown that Lats is often unrelated to the prostate. Bladder dysfunction can also cause Lats, including the juicer overactivity, overactive bladder, the juicer underactivity, and underactive bladder, and a number of other structural and functional abnormalities of the urinary tract can also play a role and mimic BPE-associated Lats. So moving on to the histology, BPH develops primarily in the periurethral and some central transitional zones of the prostate, and the hypoplastic BPH nodules are comprised primarily of stromal components and to a lesser degree of epithelial cells. These patients often present, or patients with BPH often present with asymptomatic Lats. The correlation between symptoms and the presence of prostatic enlargement on physical examination or rectal ultrasound is very poor. When symptomatic, BPH presents with Lats, and typical manifestations include storage and or irritative symptoms, as well as voiding symptoms. The physical examination generally includes a non-tender enlarged prostate on rectal examination, but like we said previously, the size does not correlate well with symptom severity. And the natural history of the disease means that the symptoms tend to progress gradually over years, especially in older patients, but a minority of patients can have spontaneous improvements in the symptoms. When there was a health professional follow-up study that described the natural progression of Lats and Bph And they had a cohort of 9,600 men who initially reported moderate Lats, and about 1/4 of them progressed to severe Lats over a mean follow-up of 5.9 years. And the progression rates rose steeply as the men aged. Moving on to the evaluation of BPE. Evaluation should always include a detailed medical history and a focused physical exam, a brief neurological screen, abdominal examination, and genitourinary examination, and always a digital rectal examination. And sometimes we can add a number of small laboratory tests to add to that. For our evaluation, we should also define the specific goals for the patient. If the symptoms are not particularly bothersome or not impacting the health, if the patient doesn't want treatment, then often no further evaluation is needed. And that recommendation comes straight out of the AUA guidelines, and is the priority of the AUA Choosing Wisely program, because these patients are unlikely to experience significant health problems in the future due to their condition and can be seen again if necessary. So just moving on to the history, we generally like to add avoiding diary onto the question, and moving on to physical examination, we just want to do a DRE, a quick pelvis and perineal exam, and a quick motor exam as well. And then the DRE, just to focus on for 1 second, a normal prostate is approximately the size of a walnut, so that's 7 to 16 grams with an average of 11 grams, firm and non-tender. And although it's not a precise tool, we can help, it can be used to help us plan our treatment going forward. Laboratory tests are not always needed, but urine analysis is helpful. Serum creatinine is not needed unless there's evidence to suggest renal impairment. And PSA testing is also not needed, but it can be used as a proxy for prostate volume when considering the use of 5-alpha reductase inhibitors. And also that we have a baseline prior to the initiation of 5-alpha reductase inhibitors, as they can lower the PSA levels. Of course, our symptom questionnaires on the IPSS is important, and post-void residuals are done very often. Additional tests can be prostatic imaging with transrectal ultrasound, cystoscopy, and dynamic testing, which has become a lot more useful these days. But the diagnosis is essentially based on the symptoms, the absence of historical history and examination findings, and doesn't always need or require histologic confirmation. Moving on to our treatment option, we just a quick disclosure, I don't have, not affiliated with any pharmaceutical companies. Although there's a lot of slides or pictures of medications, and they've yet to offer me a trip overseas anyway. In terms of our lifestyle modifications, watchful waiting is recommended as a very strong first-line approach for most patients that come in with BPE and Lats symptoms. And the first-line approach would be lifestyle modification and behavioral intervention. And they are aimed at limiting your fluid intake before bed, time of travel, or when important activity is planned, limiting the intake of mild diuretics, limiting the intake of bladder irritating, avoiding and treating constipation, increasing activity, weight control, and Kegel exercises at the time of voiding, as well as time voiding regimes, urethral milking, distraction techniques, relaxed and double voiding techniques, and bladder training. So the summary of evidence to support watchful waiting, it's a level 1B evidence from the AUA guidelines, and they describe it as a safe alternative for men who are less bothered by urinary difficulty and wish to delay treatment. The failure rate over a period of 5 years is 21%, but 79% of the patients were clinically stable. And of those, 81% were clinically stable following 17 months after that time period as well. So it's a strong recommendation to offer them watchful waiting and to offer them self-care information, education, reassurance, and periodic monitoring as well. Moving on to our medication and treatment options, alpha-adrenergic blockers are the initial pharmacological management in most patients with BPE and Lats, and the treatment effect is often seen within days. Bladder outlet obstruction is primarily mediated by alpha-1 adrenergic receptors located on the prostatic smooth muscle, and they are upregulated in the stromal glandular hyperplasia seen in BPH. Blocking these signals through alpha blockers tends to relaxation of the prostatic smooth muscle and the bladder neck and prostatic urethra. Selective alpha-1s are efficacious in relieving BPH symptoms and have fewer adverse effects than non-selective. Efficacy, recent meta-analysis showed that alfuzosin, terazosin, doxazosin, tamsulosin versus placebo all were found to be more effective than placebo, and they have similar efficacy, although there is or have been few direct comparisons. Then there's newer drugs such as silodosin, which may have a greater risk for sexual adverse events. Then the terazosin, doxazosin, tamsulosin, and alfuzosin. In a 2010 meta-analysis, they compared alpha-1 adrenergic antagonists were more effective than 5-alpha reductors inhibitors for short and long-term treatment of BPE. And then tamsulosin and psilocybin have fewer systemic side effects, but higher frequency of retrograde or anejaculation, so up to 28%. And then hypertension is also noted to be an important side effect. And the non-selective ones are obviously more involved in the selective ones. And because of this, the non-selective ones are generally initiated at bedtime, and then the dose titrated up over several weeks. The hypertensive effects of the non-selectives can theoretically be worsened by concomitant use of Pde5, but the non-selectives generally appear to be safe in this setting. Then a systematic review concluded that alpha-1 blockers do not adversely affect libido and have a small beneficial effect on erectile dysfunction, but can cause abnormal ejaculation. This abnormal ejaculation was always thought to be retrograde, but more recent data demonstrated that it can be to a decrease or absence of seminal fluid during ejaculation, with young men being a apparent risk factor. Then just to note, moving on to other side effects, just to note the intraoperative floppy iris syndrome. So tamsulosin was the one that was earmarked to be associated with floppy iris syndrome, which is a surgical condition associated with cataract surgery. And it had a triage of findings: intraoperative miosis, iris prolapse, and a billowing flaccid iris. And this means that patients undergoing cataract surgery had increased rates of iris trauma and posterior capsular rupture. So the AUA guidelines suggest that men that have planned cataract surgery, they should withhold the alpha blocker until the surgery has been completed. And then in the previous years, there was a concern linking dementia with alpha blockers. But recently in 2020, study examined the possible association between the use of tamsulosin and cognitive decline in males with mild to moderate ED. And they did the minimum scores, and they obtained them 1,000 days apart, and they did not differ significantly, which suggested that tamsulosin is not associated with cognitive decline. However, more studies are really needed to put this risk to bed. The EAU did not even include this side effect in their guidelines. Moving on to Pde5s. Sorry, the slide formatted a little bit strangely there. The Pde5 inhibitors have been shown in several randomized trials to be beneficial in improving symptom scores for patients with BPH associated Lats and erectile dysfunction. A 2018 Cochrane review of 16 randomized trials comparing Pde5 with placebo or alpha blockers in men found that they reduced symptom scores slightly compared with placebo, but with a possible increase in adverse events. They were not found to be superior to alpha blockers, and there was no benefit of adding Pde5 to alpha blockers or 5-alpha reductase inhibitors. But in a trial that compared tadalafil with tamsulosin, showed that the two drugs were comparable in their efficacy in Lats improvement. And monotherapy with tadalafil or tamsulosin similarly improved Lats symptoms in a few randomized placebo-controlled clinical trials. As of such, tadalafil has been approved for use with men in Lats in the United States. Good news for the states setting these days is that there's a new generic of Cialis that has come out, Cyfil, which is about 750 Rand for a month course. Moving on to our 5-alpha reductase inhibitors to prevent progression. They block the conversion of testosterone to dihydrotestosterone, and they are efficacious in the treatment of Lats due to prostatic enlargement. They are used to prevent BPH progression rather than acute symptom treatment. The 3 isozymes of 5-alpha reductase type 1, 2, and 3. Finasteride is a selective competitive inhibitor of the type 2 isozyme, which is mainly found in the prostate, where dutasteride is a non-selective inhibitor of both type 1 and 2, where type 1 is also found in the skin and the liver. So both drugs are effective in treating prostate volume, improving symptoms and urinary flow rates, and reducing the need for surgical intervention. The results from the MTOPS study that support the utility of 5-alpha reductase inhibitors in larger prostates, and they looked at prostates larger than 35 grams, and they showed the larger the prostate, the bigger the impact of this agent. PSA levels can be used as a proxy for prostate volume in aspect of transrectal ultrasound. Levels below 1.5 indicate that likely that a prostate is too small to benefit, and they can be used alone or in combination with other medications. And the way that they work really by decreasing the prostate volume, they improve the static component of BPE and thereby reducing the effective bladder outlet obstruction. Unfortunately, with smaller prostates, they have, unlike alpha blockers, they've got less of an effect. The only issue with them is that they can take some months to start working, and really the maximum effect is seen after 6 to 12 months. But the potential for long-term reduction has been well described, and they decrease the need for surgery. And generally, the treatment should be continued indefinitely. Then, just to quickly touch on some of the side effects, decreased libido and ejaculatory dysfunction has been well described, and obviously concern of prostate cancer. However, I just wanted to touch on the Post-Finasteride Syndrome, which describes a constellation of persistent and potentially irreversible side effects, sexual, neurological, and physical side effects, and can have mental side effects as well in a subset of men. And it is not yet known really if Post-Finasteride Syndrome has not really been well received by the medical community. There's always concern if it's still a real clinical condition, or if the reported symptoms from these subset of men are only incidental and not caused by finasteride use. The one key indisputable clinical evidence is that all reported studies with finasteride and dutasteride showed that these drugs have associated development of sexual dysfunction, and some of it may persist. And that is irrespective of the patient's age, the drug dose, and the duration of the study. However, most of the studies that are describing Post-Finasteride Syndrome are incomplete, and they are largely inadequate to assess the adverse incident reporting harm. Moving on to beta-3 adrenergic antidote for our overactive bladder. They are effective for concomitant overactive bladder and its urodynamic manifestations, which is detrusor overactivity. They stimulate detrusor beta-3 adrenergic receptors to promote relaxation, and though they are less abundant than beta-2 adrenergic receptors, beta-3 receptors are more efficacious in promoting relaxation without compromising bladder contractility. The ones that are available are Modifiable and Prevalence, and these medications may be preferred over anticholinergic agents as they do not cause dryness of the mouth. Meta-analysis of trials have found Modifiable treatment to be more efficacious in reducing urgency and incontinence episodes in placebo, and they support the use in men with common BPH. They weren't associated with an increased risk of urinary retention. However, blood pressure monitoring should be done as they can raise blood pressure. Prevalence has been shown to reduce micturition, urgency episodes, urgent continence, and increase the volume per micturition without risk of hypertension or need for titration. Anticholinergics treat the irritative symptoms due to overactive bladder in men and BPH. The hesitation in utilizing these agents is due to the concern that they may increase the risk of acute urinary retention, especially in the setting of BPE with obstruction. So post-wood residual should always be done in these patients. And these drugs should cautiously be used in men with elevated PVR. Anticholinergic and antimuscarinic agents are also used in combination with alpha-adrenergic blockers in men with BPE whose irritative symptoms persist after monotherapy. The side effects are listed there on the slide. Then we just move quickly to combination therapy, and apologies again for the formatting. In men who have demonstrated prostate enlargement and moderate to severe symptoms of BPE, so IPS of greater than 12, combination therapy is recommended. And that data is largely supported by the PREDICT trial and the MTOP study, which showed that there was a reduction in symptomatic clinical progression, episodes of urinary retention, renal insufficiency, recurrent UTIs, urinary incontinence compared with monotherapy of either agent. Again, PSA density, larger prostatic size showed a significant reduction rather than smaller size. And then the COMBAT trial, which randomized men with BPH to a combination of dutasteride plus tamsulosin, dutasteride alone or tamsulosin alone, showed that the combination was superior to either drug in improving symptoms and clinical progression, but the risk of acute urinary retention and surgical intervention, especially for men with prostate volumes greater than 30 mils, was similar for dutasteride as well as dutasteride as versus the combination. The combination of antimuscarinics and beta-3 or all beta-3 agonists and alpha blockers, there's limited data to support the use. There's some pilot study, the TAM-MIRA study showed that they were effective and well tolerated in 94 patients with overactive bladder. It was statistically superior to tamsulosin plus placebo in reducing the mean number of micturitions a day. Statistically superior results were noted also in the mean voided volume per micturition and urinary urgency episodes, but not symptom severity as associated by the IPSS. As that, the updated EU guidelines of 2022 show the combination treatment of alpha-1 and mirabegron results in a slight decrease in a number of voids and urgency episodes, and they give it a 1B level of evidence. Then just quickly, for some interest, although we do not recommend any of these guidelines or any of these treatment options, there are some members of the public that like to go for a herbal or phytotherapy before they try medical therapy. And a 2008 survey found that these alternative medicines were second most commonly used behind alpha blockers. There's very little evidence to support any of these treatments, and they are recommended against by the AUA guidelines in 2011. The problem with a lot of these treatment options, they don't have very good studies or any data behind them. Most of them, compared to placebo, show very little benefit. And because they don't have as many stringent trials related to them, the long-term safety and efficacy of the products remain unclear. And that is essentially my talk. Thank you very much for listening. This is just a quick summary taken from the guidelines, which just briefly discuss in a table view the management options for BPE and BPE-associated symptoms. And then these are my references straight out of the EAU and AEA guidelines, as well as most recent up-to-date articles. Thank you very much for listening.
Yeah, thanks a lot, Mark, for a great overview of BPH and the medical management. Do we have any questions for Mark on the floor?
Hi, Sam. Can you hear me?
Yes, we can hear you.
Sorry, I can't find the thing to put my hand up. Apologies for jumping in there. Mark, congratulations. A superb talk. A lot of work went into that. Thank you very much. Just some small print. I'm sorry to belabor it, but you mentioned that the 5-alpha reductase, I beg your pardon, the phosphodiesterase inhibitors type 5, the sildenafils and the tadalafils, are first line. Is that right? The guidelines would include them in the first line drugs. And do you know the mechanism of action in terms of improving symptoms for BPE?
Yeah, Prof. So not first line that I have, so I should have maybe described that a little bit better. So they are, you can use them as a first line, or tadalafil, you can use as a first line in men that have BPH symptoms as well as erectile dysfunction rather than an alpha blocker. Because the comparisons, although be it few of them did show that the Cialis versus versus tamsulosin was effective or the same. The mechanism of action, or how they work for BPE, is suggested to be similar to an alpha blocker in terms of prostatic muscle or relaxation, or smooth muscle relaxation. And that is really as much as I went into it, I'm afraid. It's from what I understand is they also work on your static component and have very little effect on the dynamic component. I apologize that I don't have a much better trying to find the slide that describes it very well.
I'm interested in your comment, but I had thought I'd read earlier that it in fact improves pelvic blood flow, and there's some degree of hypoxia of the bladder, which makes it overactive to some extent. So I had a more bladder-related mechanism of action, but we could go and look at that, whether there's any effect on the prostate itself. Just a follow-up question related to finasteride. I was interested to hear about the Post-Finasteride Syndrome. I hadn't encountered that before. But you mentioned it causes ejaculatory dysfunction. I wasn't aware of that. Are you sure about that? certainly the alpha blockers cause ejaculatory dysfunction, but I wasn't sure that the finasteride does. I know it causes reduced libido.
Yeah, so there's a number of trials that describe finasteride causing ejaculatory dysfunction, ranging from, again, anejaculation, decreased amount of ejaculation, retrograde ejaculation, and yeah, whether or not we should entertain the post-finasteride syndrome, I think that's not a question for me to answer. I don't think the literature is really there to prove it yet, but there have been some good studies that, or shouldn't say a lot of good studies, but there was a study from Trace in 2019, which described this post-finasteride syndrome, and then a meta-analysis a year later disproved the whole. It is these two references that I've included at the bottom here. But yeah, the finasteride absolutely can have ejaculatory dysfunction, and most commonly that is retrograde anejaculation. And yeah.
Thanks, Mark.
Thanks a lot, Mark, for your great talk. We'll just move to Dr. Ahmed